Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues and dear PGs, in last video, we discussed that when patient present to us with chronic hepatitis B, what should be the algorithm and when we will start antiviral treatment. In today's video, we will discuss that if we have decided to start the antiviral treatment, what antiviral treatment should it be? What are the options available? What are the agents? And what should be the preferred drug in any given scenario? So starting the discussion, the chronic hepatitis B, how to treat. I recommended the EASL guidelines in my last video that I follow these because these are very simple and practical. And we did see that what's the difference between hepatitis B and hepatitis C. To better understand the dynamics of hepatitis B viral treatment, we knew that the hepatitis B is a nucleic disease, it's only controllable, and we need to start antiviral treatment when it is indicated, and then we discussed the indications in the last video, and it's a lifelong antiviral treatment. This is when we discuss the algorithm. The first step in the algorithm is that of liver status, to find out what is the liver status, then evaluate what is the viral load, then go for the serum ALT levels, and the last go for the other factors. I shall share the link of this video in the description, and if you haven't watched that, you can watch that for the better understanding of this video. And this is when we concluded that if a patient has got cirrhotic liver, so any detectable level of HBV DNA, regardless of the ALT levels, needs antiviral treatment. That's the red colored group. And if the patient has got fibrotic liver, so the value must be more than 2000 units, and the ALT should be raised any level, even within the two times raised, but any level of raised ALT is required to start antiviral treatment. But if the patient liver is perfectly all right, normal, non-fibrotic, the DNA level should be more than 20,000, and the ALT must be more than 2 times. These are the clear indications when we start patients on antiviral treatment. But what if the DNA levels meets the criteria, but the ALT level is normal? In that, we discussed that the EASL guidelines give the guidance that if the patient age is more than 30 years, if there's a family history of HCC or cirrhosis, and if there are extrahepatic manifestation, then the patient qualifies for the antiviral treatment. And then we discussed another scenario in case of fibrotic liver or normal liver. If the ALT is raised, but the DNA is less than 2000, that is the low level viremia, what to do then? In this case, we discussed that the AASLD guidelines gives the suggestions that in such patients, do the age-based antigen quantification. If it is more than 1000, you start these patients on treatment. If it is less than 1000, you don't start treatment, you follow up these patients. So till now, the things were, the algorithm was clear, and it is clear. And if we have decided that we are going to start the patients on antiviral treatment, so what drugs are available? Basically, 2 categories of drugs are available. One is pegylated interferon, another is the oral drugs. In the pegylated interferon, the most data is regarding the pegylated interferon alpha 2A. A few studies do suggest pegylated interferon alpha 2B, but it's not that huge data. Maximum data is on the alpha 2A. In the oral drugs, we have got nucleoside analogs and nucleotide analogs. In the nucleosides analogs, rather the first drugs which was used in clinical practice was the lamivudine, then came the telbivudine, and nowadays it is the entecavir. Nucleotide analogs, adifovir was the first drugs to be used. Then came the tenofovir, the TDF, and TAF. The pegylated interferon is currently being used, especially if the chronic hepatitis B patients, they are having co-infection of hepatitis D as well, and the D PCR is positive. And among the oral, in the nucleoside analogs, this is the entecavir, or on the nucleotide, this is the TDF or TAF. So these, the oral drugs, these are the first-line drugs because of the resistance which was reported, which was seen with the lamivudine. Otherwise, the lamivudine was very effective in controlling the viral load, but resistance used to be the problem. So let's compare the pegylated interferon with the nucleotide or nucleoside analog in terms of the advantages and disadvantages. First, take the pegylated interferon. The pegylated interferon, the advantages is that it is given for finite duration for 1 year or 48 weeks. There is no antiviral resistance reported with pegylated interferon. It gives sustained response, but remember, it does not give sustained response in each and every patient, only few patients. And there is better HbS antigen seroconversion if the patient's, luckily PCR has become negative, LT is normal, E antigen seroconversion has happened. So the HbS antigen seroconversion is better with pegylated interferon. But the disadvantages are that frequent adverse events are reported with the pegylated interferon. It is injectable route. There is less HBV DNA suppression. It is an expensive therapy, and it's not safe in advanced diseases. Now coming to the nucleoside or nucleotide analogs or the oral therapies, advantages are they have got less adverse events as compared to the pegylated interferon. It's oral route. They are given orally as compared to the interferon, which is given injectable. Then it has got the greater HBV DNA suppression. They are less expensive and they are safe in advanced disease. But disadvantages are that they are given for long term, most of the cases lifelong, and there's a risk of resistance, especially with the LAM. And if the patient was initially LAM resistant or LAM experienced, and you give that patient entecavir, again, resistance is the main issue. You need to get a maintained response. You need to give these drugs long term. The time you stop these patients on antiviral treatment, in months or in a year or so, there's relapse, and there is less HbS antigen seroconversion with nucleotides. So if we evaluate these two, the advantages of the pegylated interferon becomes the disadvantages of the oral. Like I said, pegylated interferon is for finite duration. Nucleotide is for infinite duration. There is no antiviral resistance. Here is the risk of resistance. It gives you sustained response. It gives only maintained response. There is better HbS antigen seroconversion, but there is less HbS antigen seroconversion. And what were the disadvantages of pegylated interferon, like frequent adverse events? These becomes the advantages that there is less adverse events. Then it's injectable route, but this is oral route. It's less HBV DNA suppression, greater HBV DNA suppression. This option is expensive. This is less expensive. It's not safe in advanced disease. This is safe in advanced disease. So it's a crisscross. Advantages of pegylated interferon becomes the disadvantages, the factors, they becomes the disadvantages of the oral therapy, and the advantages of the oral therapy, in fact, these are the disadvantages of the pegylated interferon. So this is how they are compared with one another. If we go in more detail, the mechanism in pegylated interferon is induction of a long-term immune control, while the oral, they inhibits the viral replication. Treatment duration, pegylated is given for 48 weeks, while the oral therapy is given long-term until HbS antigen loss, and in most of the cases, this is lifelong. The viral suppression is moderate with pegylated interferon, and it is usually high with the oral therapy. The E antigen loss is moderate in pegylated interferon, but it is low in the first year, moderate over the long term. So it's a poor HbE antigen seroconversion with the oral therapy. The HbS antigen levels effect on this, it's variable pegylated interferon, but may give a long-term seroconversion of HbS antigen, while the oral, it's very low. The viral resistance is not reported with pegylated, rather it is minimal to none for the new oral therapies. Risk of relapse after treatment cessation, low for those with sustained response, but it is moderate if consolidation treatment provided after HbE antigen serum conversion. Otherwise, it is high. For route of administration, it is given subcutaneous injection and it is given orally Tolerability is low in case of pegylated interferon. It is high in case of the oral therapy. Long-term safety concerns, there is very low resistance, but on treatment there are side effects, and probably there are no long-term safety concerns with the oral therapy except the TDF, which may cause long-term renal problems and bone problems at the risk patients. Those patients who are at the risk, like advanced age or chronic liver disease, or the chronic renal parenchymal disease. There are many contraindications for pegylated interferon. There are almost no contraindications for the oral therapy except the very decompensated liver cirrhosis. Risk of viral resistance is no, but here it's minimal to none. So this is how we head-to-head compare these two therapies. Okay, so we have decided that we are going for pegylated interferon, who will respond better? In HBe antigen positive patient, if my patient is female, having baseline higher ALT, low viral load, and if my patient is a genotype A or B, and the E antigen, the quantification is low, and the patient is not very young, then probably HBe antigen, these group of HBe antigen positive patients will respond better to pegylated interferon. If my patient is HBe antigen negative to start with, so female again, they are good responders, but here the LT needs to be high, the viral load needs to be low, and the patient should be in genotype B because C and D, they respond very low. So I summarize, who will respond better to pegylated interferon? The female patients respond better to pegylated interferon. The initial ALT must be high. The initial viral load should be low, not very high. If patient is HBe antigen positive, the patient preferably should be genotype A or B. And if it is HBe antigen negative, then the B and C, they are better responder. D, in any case, either E antigen negative or E antigen positive patient, it's the poor responder. So this is the way, if we have decided to start the patient on pegylated interferon, who is the suitable candidate for this. What about the oral therapy, the preferred drug? If we are going, and in most of the cases, we go for the oral therapy. So what is the preferred drug in different scenarios? In decompensated cirrhosis, the TDF or entecavir, it's the preferred drug. For renal patient with renal insufficiency, if there is a renal disease, TAFE or entecavir, but entecavir needs dose modification. TAFE does not need any dose modification. Elderly patient more than 60 years, you can give TAFE or entecavir. TDF becomes a bit risky because these patients, they are osteoporotic and their renal may be compromised. For bone disease, again, TAFE or entecavir is the preferred drug. If a lady is a pregnant lady, then TDF is the drug of choice. Now data is coming on the TF as well. But if there is no clear-cut contraindication for TDF, I will go for the TDF. Women of childbearing age who are planning for pregnancy in near future, AACLD guideline says go for the TDF. The EASL says if no advanced fibrosis, therapy may be delayed until after infant is born. So this is the difference between two guidelines. Women of childbearing age wishing to make PCR negative prior to pregnancy, again, so then TDF or pegylated interferon may be considered in this patient. Previous exposure to nucleoside analogs, the TAFE should be given to these patients. HIV co-infection, the TDF or TAFE plus emtricitabine or lamivudine, these are the drug of choice in this patient. So when we are going oral therapy, we should think that what is the scenario, what is the setting, and what is the preferred drug in that very scenario. What about the combination therapy? Generally, combination therapy is not recommended by any guidelines. If somebody is using two orals, like the entecavir or tenofovir, or entecavir or tenofovir, TDF or TAFE, it's not recommended. De novo combination therapy of two NAs with a high barrier to resistance, entecavir, TDF or TAFE, studies have not found that they are more effective. Yes, drug switch or combination may be considered in treatment-adherent patients with incomplete HBV suppression, reaching a plateau during entecavir or TDF. Long-term therapy, yes, you can switch from one group to another group. This is the if a patient is on, so you switch on or you aid on the therapy. You can do that. For the oral plus interferon, it's not recommended. De novo combination has not been recommended. Short-term pre-treatment with a for pig-ellated interferon in treatment, naive patient people have used that. Okay, you control the viral load with the oral, and once viral load is low, so you start this patient on pig-ellated interferon. But this policy has not adopted general acceptance. Adding pig-ellated interferon or switching to pig-ellated interferon in patients with long-term HBV DNA suppression and any therapy, again, this is not recommended. So there may be different scenarios that either someone is starting the two oral drugs to start with, again, it's not recommended. A drug switcher combination, yes, it may be considered, but coming to the pig-ellated interferon to start with the combination is not recommended. In short-term pre-treatment to lower the viral load and then start the pig-ellated, again, not recommended. And the adding the pig-ellated interferon, switching the pig-ellated to the oral, again, it is not recommended. So what dose and duration? If the patient is compensated cirrhosis, entecavir dose is 0.5 milligram and TDF is 300 milligram, TAFE is 25 milligram, and this is given lifelong. The color coding, it's given lifelong. Decompensated cirrhosis, then the entecavir is given in the 1 milligram dose, the dose is double, and it's the TDF 300 milligram, TAFE. There is no data available, good data available in case of decompensated cirrhosis. And again, it has to be given lifelong. So if the patient has got decompensated cirrhosis, two options, entecavir or TDF. TDF in the routine dose 300 milligram and entecavir in the double dose 1 milligram. But if the patient is compensated cirrhotic, then any usual dosage of the entecavir, TDF or TAF may be given. And remember this, the therapy has to be given lifelong to prevent the reactivation of a virus. If a patient has got fibrotic liver, so routine dose of entecavir, TDF or TAF is given, and it's given lifelong. But if someone or you have decided the patient is female patient viral load is low, ALT is high, and you wanted to give a trial to the pig-ellated interferon, then for 48 weeks or 1 year therapy is given, and then response is evaluated. But if the patient has got normal liver, so entecavir, TDF or TAF in the routine dose, and again a lifelong, the green color coding. And if you decided that patient should be on pig-ellated interferon, so 180 microgram once a week for 48 weeks. So to summarize, if I say normal liver and fibrotic liver, you can give either pig-ellated interferon and the oral therapies. Pig-ellated is given for 48 weeks, oral is given lifelong. But by and large, we are starting oral therapy in these patients because they are safe, they are less expensive, and they are having no side effects. The pig-ellated interferon is contraindicated in cirrhosis. In cirrhosis, it's the oral options are available. And if the patient is decompensated cirrhosis or has an event of decompensation, entecavir is given in double dose, and its TDF, TAF data is not available. And the orals, as you see here, its duration is lifelong. For pig-ellated, this is 1 year therapy. When to stop antiviral treatment? Pig-ellated interferon, there's a defined duration of 48 weeks, and either patient responds or does not respond. For the nucleotide analogs, endpoint depends on health, the hepatic and HBe antigen status. If the patient has got cirrhotic liver, lifelong treatment is mandatory. If patient has got fibrotic liver, again, lifelong treatment is mandatory. It becomes only normal liver, and in the normal liver, HBe antigen positive, where you can think about the stopping of the treatment. If normal liver, but the patient is HBe antigen negative, again, better you give the lifelong treatment. So patient is normal liver, HbE antigen positive. So a patient, if he achieves stable HbE antigen seroconversion and there's undetectable HBV DNA, it complete more than 12 months of consolidation therapy. So a patient was HbE antigen positive with normal liver. You started a patient on the antiviral treatment, and with the antiviral treatment, E antigen seroconversion happened. PCR became negative, and after the E antigen seroconversion happened, you continue the same antiviral treatment for another 12 months, and during this 12 months, again, the PCR remained negative and there was no E antigen seroreversion. So now you can stop the antiviral treatment in this very specific group. But the patient needs very regular follows because, as I said in my last video, the relapse is very common in these patients. In case of HbE antigen negative, where the PCR remains negative, repeatedly you check that 6 monthly and the PCR remained negative for 3 years, then you can think about the stopping of the antiviral treatment. But the very close post oral therapy monitoring is warranted, and it's very, very extensive and regular monitoring. Like in the initial 6 months, you do ALT every month, you check PCR every 3 months. Then in the next 1 year, you do ALT every 3 months, and again PCR every 3 to 6 months. And after that, you go for a biannual PCR testing and later on annual testing. So it is very, very close monitoring and very expensive way. And the relapse is common. Yes, the relapse, the flare may be a good one or a bad one, but better to the patient going to the relapse and all those consequences and maybe acute liver failure, better is that you convince the patient to continue the therapy lifelong, because as I said before, hepatitis B is a lifelong disease because of the cccDNA residing there in hepatocytes, and we need to control the replication lifelong. Otherwise, the inflammation will restart it and the patient will be in trouble. So I hope I have made my point clear that when we decide to start the patient on antiviral treatment, what antiviral treatment is available. These are injectable and oral. An injectable is Spigalette and interferon alpha-2A. In oral, it is the entecavir or tenofovir. And then which one to use in which scenario, and which should be the preferred drugs, and what is the dose. We discuss this as well, and by and large it's a lifelong antiviral treatment. So inshallah, in the next video we shall discuss that how we will evaluate the response of a patient to antiviral treatment. So till then, it's Khuda Hafiz, and see you in the next video. Thank you very much.